lovely and talented Dr. Hanks is going to give us a grand round this morning. I really appreciate it. Yep, let's give her a round of applause. And because of that, I was able to dip into her CV and her faculty success. So I have a couple pearls. I felt like I knew Dr. Hanks, but now I know her a little bit better, and I'm just going to share a few things with you. She started with us in 2022. Her clinical interests are transgender medicine, robotic surgery, and global health. She enjoys rugby, college basketball, and everything in the great outdoors. A couple more things I learned. This one, I just have to say, I usually don't go back to people's undergraduate unless I'm interviewing them for residency, and then I'm fascinated by people's undergraduate degrees. I don't know why I'm fascinated by that. I have visited so many college campuses with all my children, 3 children over the past decade. The University of Mary Washington. I've never heard of the University of Mary Washington.
Yes.
Raise your hand if you've heard of it. Okay, all right, that's cool. All right, it is a public liberal arts university, a public liberal arts in Fredericksburg, Virginia, which is north of Richmond, a little south of DC. But this is the part I love. It was founded in 1908 as the State Normal and Industrial School for Women at Fredericksburg. I don't know what that means. But her undergrad major was history, and she's going to have to tell me later. I just find that fascinating. She did her MD here at UW, where she was a wonderful student, residency at University of Rochester. Then she went out to the Northwest to gain some skills for a couple of years before she came back here to join the academic fold. Lots and lots of honors and awards. One notable or a couple notable things, the Junior Fellow Prize at ACOG District 6 annual meeting in 2023. Also an Excellence in Student Research Prize at the medical school for a Shapiro Summer Project in 2023. Lots and lots of presentations and publications on reproductive health, gender services, and LGBTQ care. And one notable at a recent ACOG District 6 annual meeting in St. Louis, senior author on a prize paper called Tubes and Turns, How Politics Tied the Knot on Reproductive Choices. So I hope she went up in the Arch. For those of you who don't know, St. Louis is my hometown. And if you go there, you have to go up in the Arch. So kudos to her. Lots and lots of mentoring. She hasn't been with us very long, but so many residents and medical students that she's mentoring, so much enthusiasm. A couple of service things that I really appreciate. She serves on our research advisory committee in the department. She's also the legislative chair for the ACOG Wisconsin section and started that in 2024, which is more important now than ever. And lots of media presentations. And I got to tell you, my favorite is one of the most recent Wisconsin 15 News. Madison OBGYN encourages CrossFit for expecting mothers. So there's a lot more. She's going to talk about some work with transgender patients and gender diverse patients, amenorrhea, a topic we all care about. So thank you for pinch hitting. We really appreciate you, Dr. Hanks.
Nice. So I was really excited to stand up here and then sit down very quickly. Because I really wanted Frances Grinstead to be able to come and talk, and hopefully she'll be able to, but she is very, very thick and hopefully getting better. But I met Frances at USPath, and for those that don't know, that's kind of a branch of WPath, which is the World Professional Association for Transgender Healthcare. And I just like latched onto her. She's just this amazing researcher, super, like any study you look on, she's like some author on it, and has just done some really great work. So hopefully she will come in and talk to us. So and probably would have given a much more exciting talk than what we're going to do today. But what I thought when she said that she wasn't feeling well was I think any normal person would be like, sweet, we can sleep in. And I was like, no, the learning must go on. Sorry, here we are. What better to talk about some super niche subject that I'm super interested in and everyone else is like mildly to moderately interested in. But again, here we are. So thanks for being here and listening. This is a topic I gave a talk last spring out in Utah, and I've actually had a couple residents and PAs ask me about this subject, talking about how to induce amenorrhea in our transgender and gender diverse populations. And I think there's everything with transgender and gender diverse care is can be very nuanced and individualized and lacking research, as that theme will come up over and over again. But I just thought this would be a nice topic to go through for those of us that see these, well, everyone's going to see these patients, but yeah, just hopefully gain some pearls here. These are my disclosures. My super vanilla family. The career objectives for today, I'm hoping that we can talk through the medical rationale and benefits for inducing amenorrhea and transgender and gender diverse. I'm going to use PGD just because it's a little bit shorter, but that's what that stands for. And then identify different methods of inducing amenorrhea, including hormonal and non-hormonal approaches. And then recognizing clinical considerations, potential complications, develop personalized care plans. Again, this is a part of medicine. I know we talk a lot about shared decision making and individualizing care, but I can't stress enough how important it is in this particular population. And then apply best practices with providing compassionate and culturally competent care to TGD patients. All right. So, I don't know about you guys, but like this is like the face I get for this. And what I have found to be really helpful that I've started doing with a lot of my patients, like really anyone that has abnormal bleeding, is really concentrating on this part in particular, kind of letting the rest fall to the wayside. But I'll often draw, like I'll say like period, ovulation period, and then I just draw the progesterone line. And I talk about how, you know, for the general public, the rest of this isn't as important, but talking about this, having a steady state progesterone is what can stabilize the endometrium and keep you from having either erratic bleeding or heavy bleeding. And I've seen, since I started doing that, I've seen a lot of patients kind of have that like aha moment. And it makes a lot of sense when you're prescribing that. For the rest of us though, we do need to kind of like understand the rest of it. And as I was preparing for this at 10 o'clock last night, I thought, what better way to go through it than with an interpretive dance? So you'll give me a moment. Oh my God. Costume change. Okay, sorry. Stop. Here we are. We are starting out at the very beginning. We are thin. We are demure. We are thin lining. We are just chilling with all of our hormones. We've got little follicles that are just swirling around like a bowl of chocolate chip cookies. And they're just trying to fight to find who's going to be the winner. And estradiol's doing this funny thing in the background. We're not really sure, but she's kind of increasing and she's giving negative feedback to LH. Negative feedback, negative feedback. And then something crazy happens. All of a sudden the yoga music has switched to death metal and they switched on the feedback and everyone's like going, and they're shooting off hormones everywhere. And then our follicle comes out and ovulates. And we create the corpus luteum. And the corpus luteum becomes queen. And she starts producing progesterone like a fertility machine. And then if sperm doesn't come on the scene, she melts away like whipped cream. I had to do something because I felt so bad for you guys. No. Get this thing off. So that's the menstrual cycle. Any questions?
You need to tie off the ligaments of your uterus before you take it out.
Fair enough. All right, so what does this all mean for our patients? There was a study in 2023 that examined the experiences of 129 TGD patients and found that 93% experienced some sort of menstrual related dysphoria. 88% were interested in menstrual suppression, with the primary reason being the desire for complete cessation of menses in 97%. Okay. So menstruation, that's all to say that menstruation can have an adverse impact on mental health and well-being in this population. So inducing amenorrhea can improve their quality of life. And transgender specific challenges can be related to menstruation. I added this slide in because I think it's kind of a cool side note, but in regards to mental health and menstruation, it's important to discuss how it's affecting their dysphoria. It might not be, but as I said with the last study, many patients, it will affect their dysphoria. So the other part of menstruation that can be dysphoric is that a lot of products for menstruation are marketed as like feminine hygiene products, or like feminine care. So in 2016, I guess I'm not supposed to say brand names, but a certain brand released a boy short style underwear with a series of videos and print advertisement featuring a trans male model, and advertised for people with periods instead of for like feminine products and things like that. So I think that certain companies are kind of like starting to get it and change that way, but kind of, I challenge you to, when you're in the aisles in the grocery store, like look for that. Like it still is many places advertise with feminine products. All right, so back to individualized care. And as I said, not all patients are going to be bothered by menstruation. So it's really important to discuss a patient's goals and important to provide informed consent, obviously, and then respect individual autonomy and desire for reproductive choices. So what I mean by that is not every patient that identifies as PGD are going to want a hysterectomy, right? Like I feel like sometimes that, again, in the news too, it's like, surgeons are just always pushing this, but many patients may not want to have periods, but want to preserve future fertility. So being aware of that. How many of you have heard of the US Transgender Survey, the USTS? So that was a huge survey. They actually initially did it in 2015 and had such great responses. They did it again in 2022, and they had 92,000 transgender and gender diverse respondents. 84,000 were adults and 8,000 were between the ages of 16 and 17. And some of the findings are just, they're fascinating, but they're also a little sad. So just real quickly, a quarter of respondents, 24%, did not see a doctor when they needed to in the last 12 months due to fear of mistreatment. Of those who did see a healthcare provider in the last 12 months, nearly half reported having at least one negative experience because they were transgender, such as being refused healthcare, being misgendered, having a provider use harsh or abusive language when treating them, or having a provider be physically rough or abusive when treating them. So these patients are coming, when we see them, they've often, or many of them have had a negative experience or are afraid of having a negative experience. So I think it's really important to be aware of that when you're walking into a room. They've also, this population is also more likely to have experienced prior sexual abuse and violence, which can cause emotional distress when around pelvic exams. So they might choose a method for amenorrhea if they're hoping to induce amenorrhea that doesn't involve a pelvic exam. So hoping to not have like an IUD or something like that. Again, this is not universally true, but just something I want you to be aware of when thinking about this population. All right, you guys know this gal, hormone monster. So when discussing hormonal manipulation, it's important that you first start with talking about a menstrual history. It can be helpful in terms of knowing what tests to order and what treatments you can offer a patient. Again, just like with regular abnormal uterine bleeding. But caveat being, is your patient taking testosterone? If they are taking testosterone, the next question is, are they taking it? Are they taking it at the same time, like as prescribed? A lot of patients that are on testosterone are struggling with insurance things, with certain pharmacies not carrying it. So they will very often have missed doses, and sometimes they don't always say that right off the bat. So you need to ask about that if they are missing doses or if they weren't able to pick up their prescription for a week. It's not uncommon to have breakthrough bleeding. So that's a really important part of the history to understand. The other part too is if they're on testosterone and they, they've been on it for a year, let's say, but I often will say, well, what were your periods like before testosterone? They're like, oh, they were super heavy and horrible. And like now sometimes I have breakthrough bleeding. Then I start thinking about, should we be thinking about fibroids or something like that? So really getting a good menstrual history is important. So testosterone does suppress menstruation by disrupting the HPO axis, leading to low LH and FSH and inactive ovaries and thinning the endometrial lining, all of which will decrease bleeding. But the full effects on the hypothalamus and pituitary are not completely understood. So again, just remembering that those inadequate or missed doses can lead to an inadequate gonadal suppression and then breakthrough bleeding. So this is a chart from UCSF transgender guidelines. For those that don't know and have any interest in knowing, if you just Google UCSF transgender guidelines, the site that comes up has a whole list of things on the left column. The most helpful for me is like masculinizing therapy, feminizing therapy, and within that it has the testosterone dosing. What I mostly do is the top one. That's injectable testosterone, and this shows the doses. And then some people, if they have needle phobia or just don't want to inject themselves once a week, we'll do a gel and usually do this one. And then you have to do lots of math to figure out the conversion, but you can get there. So again, going through with them if they're taking it appropriately and taking the right dose. So it's also can be very confusing about drawing up the right amount. So I usually go through like what exactly are you drawing up? What's the concentration, etc. So it does evolve a little. All right. So going back to the timing of testosterone effects. I really like this chart because it's colorful, but there is one on UW Health. What is it? Health Facts for You has one that's in black and white that we give to patients. But at any rate, when a patient is starting on testosterone therapy, if they decide to do that, they should have cessation of menses in the first 1 to 6 months. That is to say, I let patients know that it might not happen by month 2. So like, let's give it till, at least 6 months before we start looking at other causes. But it does happen relatively quickly in relation to all the other changes that can be happening. All right, palm coin. So if we rule out testosterone, or if you're being the cause of breakthrough bleeding, or if they're not on testosterone, then you just go into your workup for abnormal uterine bleeding. I'm not gonna kind of go too much into that because I hope that you all know it. Okay. The next question I had was if you decide that it's not a structural, going back to testosterone, does anyone know when you check a testosterone level for someone that is taking injectable testosterone weekly? Like what the timing is for that? I was looking for Olivia. Olivia was in clinic with me yesterday and I was like, darn it. So this is what, how testosterone when you give an injection, how the pharmacokinetics work. So in the first day or two, you're going to have the peak level of testosterone, and then it kind of tapers off. So we generally check a testosterone level at day 3 to 4 because that's kind of like mid-cycle. So that's another thing, is asking the patient, when they got their testosterone, making sure that they know to get it at that day 3 to 4. Because if you check it, on day 1, it's going to be falsely high, or later falsely low, or if they've missed a dose. I had a patient yesterday that was like, oh yeah, I checked my levels, but I forgot to tell you that I hadn't taken it in 2 weeks because I didn't have access. So it's like, well, that's not a helpful lab anymore. So really kind of clarifying that. All right, back to our scary diagram. Oh, wait. There she is. Okay. So we've ruled out, we've decided they're taking their testosterone. We're happy with that. When we talk about ways to treat breakthrough bleeding on someone that's on testosterone or not, one of the first things we can go to is progesterone. So again, I talk about with this line and how it can stabilize the lining of the endometrium. And it is not contraindicated to give someone on testosterone progesterone. So I usually have that conversation. There's, just like most things, it's not, it doesn't have a lot of research, but it's not been shown to be dangerous by any means. And it's not going to change anything with their masculinization if that's what they're hoping to get out of with testosterone. So when I was studying for boards, I felt like I didn't really have a good understanding coming out of my residency of like the different flavors of progesterone. And I found it really helpful to go through because I think that each generation kind of has a little different, I don't know, zhuzh to it. So now I kind of like think more about that when I'm prescribing progesterone. So with our first generation, that's your norethindrone and medroxyprogesterone acetate. This is does have some mild acne, oily skin, can have lighter periods. It does have some diuretic effects, and is kind of what's in the mini pill and kind of our more common progesterones. Second generation is levonorgestrel, so that's what's going to be in IUDs. It can lead to mood changes. Some people have weight gain with this particular progesterone. It is more effective in preventing ovulation, but there's also a slight increase in androgen-related side effects. So most of oral contraceptive pills with estrogen are going to be first and second generation progesterones. They do have a higher androgenic profile and a lower risk of venous thromboembolism. And then just a quick side note about pain control with IUDs. I feel like this has like become a hot topic because of social media, but for those that don't know, ACOG does have a kind of a statement on this, and I think I just went through it the other day, and I do think it's really helpful to look through. But really, just to quick go over that, pharmacologic interventions are like the lidocaine cream, gels. I know our clinic has lidocaine gel in it. I think all clinics do, right? So you can offer patients that's something that they can place themselves and then sit for 10 minutes before you do an exam. NSAIDs we know are great. Cervical block. I offer that to most patients. I do say like this does involve 2 extra pokes and can be uncomfortable being placed, but has been shown in studies to decrease the pain of an IUD insertion. Benzodiazepines or anxiolytics, the ACOG suggests that you can offer it. It's not going to help decrease the pain, but just people that are anxious overall, I think that it is helpful, but just letting them know they need someone to drive them home. Narcotics are not great. There's not really strong evidence that they help, but in some situations, again, individualized care. For this patient population, vaginal estrogen can sometimes be helpful. So the people that are on testosterone, it does thin the lining of the vagina, so it can make exams uncomfortable. Doing vaginal estrogen, either cream or pill for the nightly for the week before the exam has been shown to be helpful with that. And then non-pharmacologic interventions, therapeutic language, comforting environment. Our clinic lights have the like light fade thing. So that's kind of, nice if they want kind of a lighter light. I had a patient the other day who we had a scheduling snafu and they were supposed to be there for, well, it was a colposcopy, but she was there for a consult and then it was 8 a.m. and then I didn't see her. I added her on at the end of the day because I'm a bleeding heart. And I was like, go home, make a playlist. It'll be great. Of course, Taylor Swift came up somehow. I don't know. When she came back, did you just give a thumbs down up there? I saw that. She came back in her playlist. She was like, she did get a bento, so she was a little loopy, but she was just like, look at my playlist name. And it said, my OB-GYN's a Swiftie. But, then we listened to half the song and it was over. All right. And then patient-centered care. So giving realistic expectations. I've stopped saying, you're going to feel a little pinch and a cramp, BS, this hurts. I now say this, some people, it really isn't a pinch and cramp, but some people it really hurts. And so I think that minimizing that pain is not something we should do. So I just say this, some people have a lot of pain with this and this could potentially really suck, but I'm going to try to do it fast so we can get it over with for you. So giving those realistic expectations, I think is really important. And lastly, if someone, and I've had several patients that really want an IUD, but just I just can't, I know I cannot physically, emotionally, mentally have a pelvic exam. We have ORs, right? We have the surgical center with moderate sedation. There are other options. You don't have to be awake to do this. And I don't think we need to do that for everyone, but for certain patients, I think it's really important. All right, back to our progesterone. Get off my soapbox. Third generation is your desogestrel, norgestimate, etonogestrel. For those that don't know, this isn't a uterus, this is the next one up. So less likely to cause acne and oily skin. They're more neutral with the positive or positive for mood effects. They do have a slightly increased risk of blood clots compared to the second generation progesterones. Yeah, so that's what I want to say about that. So I really am just more excited to get to fourth generation. This is my favorite generation. So drospirenone. I love drospirenone for people that have more mood effects with their periods. I have found that people that have more PMS-like symptoms, PMDD, especially when they say I become a raging bee. I think drospirenone, I don't really understand how, but it really does a nice job of just kind of making people's mood a lot better. And I think it can be a game changer for a lot of people. So unfortunately, they still have a very good safety profile, but they do have a slightly higher risk of blood clot than the second generation. So I feel like that was in the news 15 years ago. But just something to be aware of, but I think otherwise it's a really great option for people. So, so pros and cons, the adverse effects of progestins include their bone health concerns.
Hi.
Get
How are
into that.
you?
Hi. Fluid retention, headaches, progestation. So I talk to people about it's the hormone that gets ready for pregnancy. So sometimes people feel bloated, breast tenderness, things like that. Yeah, I'm not really talking about subdermal implants because those are great forms of contraception, but I don't think are good forms of inducing amenorrhea because their bleeding profile is just kind of all over the place. All right, so estrogen and progesterone. Again, This is not contraindicated for TGD folks. It's not contraindicated for someone that is on testosterone. However, patients that are hoping to have more masculizing effects might hear the word estrogen and be like, wow. So you could talk to them about this is, you know, very low amounts of estrogen. It's not going to like negate what you're taking, but to be aware. And then of course, the contraindications with high blood pressure, VTEs, smokers, things like that. So good to go through that. All right, non-hormonal options, TXA is great. And then talking, maybe patients do want surgery, or maybe that is their goal, is to ultimately have a hysterectomy. Quick side note there for those that don't know, we, just like political side note, since the executive order this year, UW Health has decided to advise us to not, and I know a lot of us don't see patients younger than 18, but to not discuss hysterectomies with patients that are younger than 18. So if you have a patient that is asking about that, say, great, would love to chat more with you about that, but we do need to wait until you're 18 years old. And I'm happy to kind of like go into more detail if anyone wants to talk to me about that. All right. On that note, tranexamic acid, how does it work? I don't have an interpretive dance for this, but tranexamic acid, it works by preventing breakdown of clots. In fibrinolysis, plasminogen is activated into plasmin. Plasmin then digests fibrin and breaks down the clot. So TXA binds to plasminogen, blocking its activation to plasmin. With less plasmin, fibrin is preserved and the clot stays intact longer. So I don't usually say all that to patients. What I say is it makes your bleeding stop. And I think this is very helpful for people that have heavy bleeding because we only give it for 5 days. People that have that breakthrough spotting, I don't usually talk about TXA because I don't think that that's really as helpful for those situations. And then again, if I think that going back to doing a hysterectomy, doing surgery, I'm not talking about ablation because a lot of my patients at least are usually coming to me at like 20s, 30s. And as most of you know, ablations only last about 5 years and then it's hard to sample the cavity after that. So people that do ask about ablations in their 20s and 30s, I usually am like, probably not. You know, if they are interested in removing their reproductive organs and they're over the age of 18, then that's a conversation about future fertility. So I think it's really, it's tough, right? When you have an 18, 19, 20-year-old who is talking about not wanting any future fertility. That's fine, but I think it's very important to talk about what that means. So I usually pull out the diagram and I'm like, this might be silly, and like, maybe you know this, but like, this is where you can carry babies, and this is where the eggs come to make babies. So like, if we remove this, you can't carry a baby. Like, I really break it down like that, and a lot of people laugh at me, but I think it is really important to just like say it out loud. And then what I think is like fascinating is what to do about ovaries. We don't have a lot of good research. And so that's what a lot of my research is looking at, is what to do if we leave ovaries or not. So I talk to people about our ovaries. Are they contributing to your dysphoria, having them there, or do you potentially want to do an egg retrieval in the future and someone else could carry a pregnancy for you? Some people don't realize that's an option and are interested with that. Again, we don't know effects of testosterone long-term on ovaries and future fertility. There have been many documented cases of people getting pregnant that have been on testosterone for a long time, so it is possible. But I think it is a very like nuanced and important conversation to have. Other just points I want to make about oophorectomy is letting patients know that if they do keep their ovaries and they develop pelvic pain and have to go to the ER, that they do need to tell them that they have ovaries. And sometimes I can see people be like, oh, that would contribute to my dysphoria. And I'm like, that the chance of that is low, but like, I just want you to know that that is a possibility. So sometimes people will talk about, okay, maybe I want to remove one and keep the other as like a backup, because in the current political climate, people are worried about access to testosterone. And if they don't have any ovaries and go off their testosterone, they have to go on estrogen for bone, heart, and brain health. So if they do decide to take one out, I usually take the right out, because if they develop lower right quadrant pain, we know it's the appendix and not the ovary. And it's easier to get to the right ovary though. But that's just kind of my thing. All right. So back to the individualized care. Again, it's really important to talk to patients. I think this abnormal uterine bleeding consult is a lot longer than someone that is cis female, because there's a couple different extra layers, but it's not rocket science. It's still very doable by really anyone in this room. And I think it's really important to understand where your patient's coming from. Again, knowing, not just assuming they're on testosterone, not just assuming they want a hysterectomy, kind of like looking, figuring out their goals and how menstruation is affecting their life. And then also, if you're going to talk about medication, just remembering to go through the regular, making sure they don't have any contraindications to starting something with estrogen in it. And then understanding like chronic conditions and complex medical histories, and where your treatment can fit into all of that. It's in terms of following up and monitoring. So you can think about laboratory tests to monitor hormone levels, bone health, and potential complications. Again, if someone's on testosterone, we usually, if they've been on a steady dose of testosterone, we usually just check once a year. When we're first starting, or if we're making dose adjustments, I check it every 3 months, just to make sure that we're in a good range. Bone health is a little more confusing. It's hard. We don't really know if we should be getting DEXA scans if DEXA scans are expensive. So there haven't been guidelines that say we should be getting DEXA scans on younger individuals at this time, but stay tuned. And then managing side effects as well. And then timing and the need for long-term follow-up for patients with ongoing hormone therapy, I just kind of talked about. All right. All right, so then again, recognizing the societal expectations and stigma around menstruation, and then creating oh, did I do something where I knocked it off? A non-judgmental clinical environment. And the last part I just had a case that we can talk through. I just think that that's sometimes helpful. I can just read the case if this is coming up. So the case is a 25-year-old transgender male presents with persistent abnormal uterine bleeding, despite being on testosterone therapy for the past 18 months. The patient reports increased gender dysphoria due to bleeding and seeks management options. So my next slide says, what do you do? So you're going to do an H&P. You want to know how long the bleeding's been going on, if they're taking their testosterone therapy, if they're taking any additional medications, then going to labs. I would check their testosterone, what days? 3 to 4 after their injection, right? To make sure that they're actually have testosterone in the range. When you read different places, there's different ranges everywhere, but I usually say anywhere between like 300 and 900 to 1,000 is a good range. Anything over 1,000 is a little bit too much, and less than 300, they might not be having menstrual suppression. You also want to offer STI testing if appropriate, and then TSH I think is also helpful. And then if they reported having really heavy bleeding beforehand as well, I'll offer a pelvic ultrasound. Again, I talk to patients about this is going to be, can be uncomfortable. It is a wand in the vagina. And then we talk about possibly doing like lidocaine gel or if they might need an anti-anxiety or things like that. If they're like, absolutely not, I will sometimes, if they are lower BMI, write in the order to just do a transabdominal ultrasound, because I think, you know, if it's a big fibroid uterus, you can usually see that with a transabdominal ultrasound. And then I just like make sure that the radiologist or the scanning person knows, like, please do not, just don't talk about pelvic ultrasound, just so that they're aware. All right, so my slide that should be up here. So total testosterone is 345. Your TSH is normal. H&H is normal. Transvaginal ultrasound shows is normal with multiple follicles in bilateral ovaries. Would you be surprised by that at all? Follicles in the ovaries. So they're on testosterone, right? So it's very common to see like a PCOS picture with exogenous testosterone. Doesn't necessarily mean it's a cause of bleeding, but just something to think about. So I would say that the testosterone is a little bit on the lower side. So you could talk about if he's missed any testosterone doses. Is he happy with the effects of testosterone? Does he want to try increasing it? If there's room to go up, that could help with menstrual suppression as well. And then if all of that is good and we're not going to go up on the testosterone, I think that offering some sort of progesterone would be reasonable, or an OCP or an IUD. Excuse me, non-hormonal medical treatment, again, TXA if they were having heavier bleeding once a month. And then I think this would be a great opportunity to talk about goals. Is this a person that wants to have a uterus moving forward, or are they actually here because they wanted to talk about having their uterus removed? All right. Key takeaways, inducing amenorrhea is an important aspect of gender affirming care for many TGD individuals. There's a variety of methods that exist, many of which you guys are well versed in, but individualized care is crucial in this population. And then I just had some cute pictures of my family. And I wanted to just say thank you to everyone, especially my MPA Ronnie, who puts up with all my crap, and then my boss, Amy.
We have time for questions. Let's do the M&M code, and let's thank Jamie for getting all of our CME stuff done in like 24 hours. So we missed the CME code earlier. Can you say it out loud?
TOV
TOV
QEV.
QEV. TOV QEV. Did I say that right? Okay. Okay, cool. I wanted to say that, and then I think we have a few minutes for questions.
Yes.
I have a question. It's kind of maybe not on the scope of this, but what about menopause? Or
Menopause is awesome, everybody. I'd say.
I actually got a very smart medical student. I had a student ask the other day, like, what do you do? And I said, gosh, I have no idea. So at least
Like elderly, you're talking about patients that have gone through menopause that are.
well, not necessarily gone through menopause, but someday when these patients who are in their 20s, 30s, 40s, who are now starting on testosterone, do you think like continuing testosterone, will the dose recommendation be to decrease it? Like kind of like a natural way?
There's like so many, like, you guys know I go to like way too many conferences, but there have been a lot of talks about like elder population. I haven't gone to any, and I need to go to them, but because I currently don't have that many patients. I recently had a patient who, she was so rad. She was like 50, in her early 50s, but she was like, I think I've been non-binary my whole life, but I just learned the term. And I just realized like what that means, and I want to, and they wanted to start on just like a low dose testosterone. And so when in doubt, I call Ronnie Hayone and I was like, is this okay? But I think like you can do, like I do even lower than the recommendations. And what I found with that, and testosterone is also being looked at a lot with like perimenopause and premenopause. And what I hear is like the mental clarity and the increased libido people are very happy with. But I do warn them that with testosterone, you can have the increased clitoromegaly and the increased hair growth. So some people will be like, well, I don't, that like, I'm okay. But for some people it's worth it. So like, those are like the four things I'm just like, the good thing is like mental clarity, increased libido, but the downside is this. I don't think, to your question, that there's like with being on testosterone, it's like any like negative. There are like the cardiovascular like risks that we do talk about, and so checking like a lipid panel once a year is something that should be done. Making sure they don't have any like other risk factors for cardiovascular health as well. It would be like the only thing. Yeah.
Okay, I have a question and then a comment, a couple of pearls that I've learned from my primary care colleagues and derm colleagues. So sometimes when you start testosterone, the side effects, aren't always known or what you're going to experience. And one of them is hair loss, and most individuals do not like the head hair loss. So a couple of things that I've learned from dermatology and primary care, there are three medications that are quite good. We all know about minoxidil cream. That's hard to use. Minoxidil oral has been approved for androgenic hair loss. It's a very low dose. It's very safe. Sometimes you can get some lower blood pressure, but it increases the blood flow to the hair follicle. And then
Do they not get like growth all over that? Because I had that happen recently where the patient was.
You can get some growth all over.
So you would still do that like just try for patients that are like.
If they're really concerned about it. The other two medications that work well are Propecia, which is a 5-alpha reductase inhibitor and blocks testosterone. It blocks about 35% of Propecia does. Very safe medication, very low side effect. Another one that you can use is Avodart, which is 5-alpha reductase inhibitor too, but it blocks 90% of PhD. So 3 good medications to think about, because it's sometimes hard to get across that hair loss is permanent. And it starts at 1 to 6 months, and we don't know how you're going to be affected, but it is permanent. And then the comment or the question I had for you is, with ablation, do you ever have young individuals come in who want ablation just to temporarily, they're not quite ready for a hysterectomy, but they want something permanent, and you could do an ablation up to that point of hysterectomy?
That's a good question. I haven't had anyone ask that or make that plan yet, but I mean, that's definitely a thought. I guess if I was concerned about bleeding, I might want to do like an endometrial biopsy before. And just remembering testosterone's not birth control. So if I did an ablation and they were someone that were sexually active in a way that they could get pregnant, I would just kind of like stress that the ablation testosterone could be at higher risk for ectopic pregnancies. But yeah, it's like, I don't think it's a crazy idea. But yeah, have you done that?
Once.
I mean,
It gets a little nerve-wracking.
yeah, I just worry about like follow-up and like, yeah, we have like so many younger and a lot of patients that like, work at like in their 20s, work at like might not be here in 5 years. I don't know, but yeah, that's a good thought.
All right. I think we'll need to end there for timing, and then we'll come back at 8:20 for NM, and let's give Dr. Haynes a round of applause.